So with no further ado, I'm going to ask our first speaker, George Justison, to come up. George really needs very little introduction. He's already presented today and gave us a brilliant presentation, so we'll run straight into it. Thanks, George.
Thank you, everyone, for hanging in there with us today. And we're going to talk about dashboards and have a little conversation, I hope, at the end of what the future needs are and what we need from our industry partners. You've all seen my disclosures, so we're going to talk about characteristics of a good dashboard, how to make it relevant to clinicians, and then some examples of how you may use it to affect change in your practice. But, you know, a dashboard is your story. It's the story of your clinical life. It's the story of your patient's life. And dashboards are important in communicating your story, not only externally, but most importantly, in my opinion, to your team, right? So if we look at clinical performance feedback theory, there's a couple things that you need to remember about your audience as you're designing a dashboard. The first thing you have to remember is we don't all have supercomputers in our brains, right? So we have limited capacity to absorb data and respond back to feedback. And so feedback interventions that require less work, less resources, most effective. We need to understand the identity and the culture of who we're communicating to, right? So healthcare professionals, you know, we all are pretty strongly opinionated about how care should be provided, and that influences the way that we interact with feedback. So we need to make feedback that's personal and aligns with important aspects of our care. And lastly, behavioral induction, which says that feedback should directly support clinical behavior, right? And individual patient care. So there's a list here of about 10 best practices that you should check off when you're designing a checklist, right? The data has to be credible. People have to get the feedback as soon as possible, live, real time, right, would be ideal. Make it individual, be specific, but still give comparison to our others, to our peers, right? Recommend feedback that we can control. Make sure you have a SMART goal, right? Specific, measurable, achievable, relevant, time-bound. Provide the same feedback in more than one way, right? Everyone reacts differently to different types of visual presentation, different ways of data analysis. So present the same thing in more than one fashion, right? Minimize the cognitive load for the feedback recipient. And then as you start to talk about your dashboard, you need to have this peer discussion through social interaction, right? And you need to make sure that you prevent defensive reaction to feedback. So, you know, discussions about dashboards are never personal, never about what you did wrong. It's always a learning and a growth opportunity is the way we present it. Quickly, there's a little bit of difference between the scorecard and the dashboard. Scorecard, something that you use as a leader or a hospital administration. It's strategic, it's done infrequently, and it really kind of provides data about who is in charge of a particular goal and what their status is. Whereas a dashboard more refers to something that you do for your frontline operational staff, and it's live or near real time. Here's an example of a dashboard. We just had a great presentation from Pat at Cleveland Clinic, right, about auto transfusion and auto log. This is our auto transfusion dashboard, right? And this is a really simple example of a dashboard. This starts with just an Excel spreadsheet, okay? And then the overlay you see here is in Microsoft Power BI. And so what this allows us to do now is, this is live, it's online. We can log into the hospital intranet, and anyone can see this, and they can drill down data that's both time specific. They can get their individual data by selecting the staff, but it shows all the metrics of our auto transfusion program: how much blood we gave back, how many units we saved, the quality control of each of our devices, right? So a lot of the hospitals, if you go and look, have a large Microsoft bundle that they purchase or license. And they probably have Microsoft BI in that bundle. And so you just need to sort out someone in your facility that can help you do this overlay. But it's really simple off of just, an Excel spreadsheet. You can also have operational dashboards, and operational dashboards might be used to help you manage your staff, right? They show workload, which might help explain the need for an N+1 staffing model. They can show variation in cases that can justify additional staff or on-demand staff. They can explain what I call the unpredictable chaos, all right? They help keep a check on work-life synergy, right? And that's helpful in keeping team engagement and satisfaction. And so some of the sources of data for this operational dashboard might be payroll productivity reports or budget variance reports. And here's an example of one of our operational dashboards. It shows us staff productivity. It shows us how good we are in compliance with our operational budget. But the one I really like is the graph in the top right corner. And this shows variability day to day in our caseload, right? And so it just shows how much chaos or variability there is. There's a nice trend graph going in the right direction, right? It's growing, and the 95% confidence interval is pretty small. But we have huge fluctuations from day to day, and this is what I call the chaos in our operations, right? So some of the tools you'll need to create a dashboard, right? You'll need some sort of database. Like I said, it can be as simple as a spreadsheet. It can be more sophisticated, like an Access database or a SQL Server database. You need to map how you're going to get data into that database. And then you need to have a process for validating that data, not only on the initial build, but how are you going to ongoingly check for errors? For example, one of the things we do in Excel spreadsheets is we'll put in smart logics, right, to give limits, right, for data that they can enter into a cell. So it checks for things like typos or errors or, outliers, things like that, to help minimize the amount of time you have to spend scrubbing data. And then you'll need some sort of presentation tool. It can, again, be that Excel spreadsheet. Maybe it's just simple graphs that you create within the spreadsheet, or maybe you use some business intelligence software like Tableau, my personal favorite, or Microsoft BI, all right? And what these presentation softwares do is allow you to quickly rearrange data and look at different arrangements, and we'll look at some of those. Lastly, you might want statistical analysis tools, program like Stata or something like that, especially if you're going to use these databases for more intensive research and want to show more statistical analysis. So we all think of electronic records, right? A lot of the heart-lung machine manufacturers provide a platform that allows us to do printed records or to feed into Epic, and those can all be used to generate your perfusion quality database. But we're also very interested now in live quality scores. So one of the things that our team did is we found it very helpful to have a ranking system for our cases so that we could start to identify trends and outliers. We came up with the 7 metrics that we thought described a perfect perfusion. And this is what we call our perfect perfusion dashboard. And they have some things that are all related back to standards or guidelines somewhere. Some of them have discrete values, and some of them also have time-based elements to it. Like, for example, we say the mean arterial pressure should be not less than 55 millimeters of mercury for a total aggregate of 20 minutes, for example. And so having a scoring system like this, now we can feed that into our quality database. So as we enter data into our quality database that you see here, basically an Excel spreadsheet, we can then program that Excel spreadsheet to automatically calculate a score based on these 7 metrics. If you check all 7 off, you get a score of 7. If you missed one, you get a score of 6. And it's just a simple ranking system. But what this does is it gave the perfusionist immediate feedback at the end of their case of, hey, did everything go well on that case? Or did I miss something? And it allowed them to review it, right, while the case was still fresh in their mind. And if you link that to some sort of outcome, then you can start to see data that supports in the clinician's mind that, hey, this is a valid feedback tool. Like, for example, we can relate our scoring system back to acute kidney injury rates. So people with a 7 score had a lower acute kidney injury rate than people who had a lesser score, right? And the same with delirium. People who have a higher score of 7, right, there was less post-operative delirium. So that's helpful in giving people some validation to this ranking mechanism. So business intelligence software is kind of cool, right? This is an example from Tableau that allows us to then do some peer-to-peer conversations or discussions about outliers in our dashboard. And so what you see here is you see procedures, you see the star rating for those procedures or the patient score, and then across you'll see de-identified perfusionists. Now, if we were doing this at home in real, everybody's name would be up there, right? So you could see your data, and they could see mine, and they could see everybody's individual data. And then in this, what we're looking for is we're looking for the average mean arterial pressure across all cases, and then the position of that number is on a time scale. So what this tells us is the average mean arterial pressure for the entire cardiopulmonary bypass run and the average number of minutes where they had an excursion. And so you can see overall, it's pretty tight among all the perfusionists, but then we can go and look at the outliers. We can say, oh, there was this one double valve, right, that had a 2 score. The mean arterial pressure was good, but they had, 50 minutes, 60 minutes of excursion. And now we can go back and say, all right, we can identify that case. Let's dissect that case and figure out what went wrong, right? And so this is a good example of using a dashboard to identify the outliers, right? If all of these were in a single individual, well, then we would have to help that individual improve their practice. If it's random like this, then we can dissect those individual cases. But just sharing data a lot is enough to sometimes improve performance. So this is the improvement that we made in the Nader DO2 by our case ranking from one year to the next, right? So just showing people that their cases, once we dropped below a point score of 5, we were really below our threshold of 300, right? And just by seeing that data, they made dramatic improvements the next year. First of all, we got rid of all the number 2s cases, right? But everyone else moved up their Nader DO2. So sharing data drives actionable change, awareness modifies behavior, and that improves the results for everybody, right? If you're lucky enough to get a hold of financial data, then you can take things that you learn in your dashboards and give some conclusive financial results to them. And this is a result of looking at one of our dashboards on hemoglobin management. One of the things we identified is we had the problem with preoperative anemia, right? And so we wanted to illustrate back to the hospital administration why we needed more resources to enhance our anemia clinic, right? And so what this demonstrated to them is that if you have a patient who has anemia and that person gets a transfusion, their cost of doing a CABG surgery was twice, right? It was more than the patient who had anemia and didn't get a transfusion, and it was more than those patients without anemia, right, who didn't get a transfusion. So this helped us to support things like, hey, maybe we need some different components in our circuit so we can reduce our hemodilution volume. Maybe we really need to consider iron infusion preoperatively in these patients, right? As we've heard earlier in this conference, that supports reduced postoperative transfusion. So again, clinical dashboards, here's our 10 items, right? How we use that, electronic records, procedure grades, unblinded reports, a good selection of the data, show data in multiple presentations, right? And have frank, non-threatening peer discussions about the data, right? So these are all good examples of what I call static or retrospective dashboards, right? This is all analysis after it happened. But really what we need going forward is real-time dashboards. So they're in front of the clinician while they're actually doing their work. And so here's the challenge with those. We've had a lot of conversations the last couple of days about area under the curve, right? And as you all know, it's a product of depth times time below a goal, right? And we know from many good studies, these were mentioned by Rob and others, Mukeda, for example, showed that if your DO2 is less than 300 for more than 15 minutes, right, you have more AKI. Oshida, right, a single large area under the curve, predictive of AKI, right, as well as the cumulative sum over the case. So these become a bit more challenged, right? So imagine you're doing a bypass case, right? And you have your DO2 up there. That's good, right? So how do you keep track every time that DO2 drops, right? We need to know the area under the curve. And keeping track of those areas under the curve, even if you have the number up there, right, of this cumulative AUC, and that's possible now with a lot of the perfusion management software, right? But it gets more complex because now we start interacting other variables, right? We know it's more than just DO2. It's mean arterial pressure. It's fluid balance. It's all these things cumulatively come together. This is a great paper from Trent Magruder. If you haven't read this one, the reason this is important is because Trent linked area under the curve of low oxygen delivery to the STS composite morbidity score, right? So now you have something that your cardiac surgeons are interested in, right? And you get their attention in this. So there's been a lot of discussion about machine learning, artificial intelligence, right? A lot of work going into understanding how that impacts acute kidney injury. this is a good paper that used machine learning to identify the top 10 features that influence acute kidney injury. The problem with this is it was really devoid in bypass characteristics, right? We also know that any thing that includes pre-op, intraoperative, and post-operative results give us the most accurate results in predicting acute kidney injury. So this is a great paper recently produced, published by Marco Ranucci, that looked at different GDP parameters over time and their influence on acute kidney injury. And what's important about many of these parameters, they're not all linear. Some of them are a U-shaped, right? So where it goes up if you're above a target, it goes up if you're below a target, right? For example, the mean arterial pressure. And he showed us the odds ratio of that. So here's an example of how we use that machine learning. We've been doing goal-directed perfusion for more than a decade now. And so we took the last 5 years of our GDP data set and we ran it through an XBoost machine learning algorithm. And we were able to predict AKI 91% of the time with this algorithm. And so what this gave us then was a hierarchy, a priority of factors that impact AKI. And you can see in our data set, the number one thing was whether you got a packed red blood cell transfusion. But then you have nadir DO2, you have the mean DO2, and you have some time below things like pressure. You have preoperative things like glomerular filtration rate, gender, etc. Okay? And so now we can package those into a dynamic critical care score. And this is what we're doing in the Spectrum Viper process. A lab can take all those parameters. We can dictate the shape of those curves and have set points along the shape of that curve, and we can also apply a weight to them. So for example, we know DO2 might be more important than the maximum arterial blood pressure, right? So we can add more weight to that. And then what we have then developed then is this dynamic dashboard for the perfusionist. And in this dynamic dashboard is this number you'll see called GDP, and the top one you'll see it's 95. And so what this process does then is it analyzes all these parameters live time for the perfusionist and gives them a constantly moving score. And then they have something that falls out, then they get a compliance alert, and that lights up the screen. So now instead of trying to synthesize 10 or 15 parameters at one time, you let the software and the dashboard do that for you, and it gives you a score, and then it directs your attention on what to follow up with. And so this is an example of where we think live clinical dashboards are going to go. It gives credibility to the data, it provides feedback instantly, and it's individual data that they can then react on during the case rather than waiting for the post hoc analysis. All right, so in conclusion, reasons for perfusion dashboards: consolidate data into actionable items, it helps reduce the cognitive load, and it focuses the attention on what's important and actionable at the time. Keep it focused on your institutional priorities. Give the team members immediate feedback, right? So showing feedback as it happens helps to reduce those excursions and reduce variation, right? And that's really what you want to do with a dashboard, is reduce clinical variation in your practice. Thank you very much.
Well, thank you, George. You didn't disappoint. That was a really lovely presentation on a topic that's incredibly important, that we're in an era where we have a lot of data available to us. But we need to be in an era where that data influences our practice as we've got the patient on the table. So do we have any questions from the floor? Richard?
Hi. So in your paper, there was, like most associations with AKI, was for packed red blood cells. Do you think there can be a bit of bias because we don't give blood cells for no reason? We usually give it for low DO2, and we know that low DO2 causes that. So how can we distinguish between whether that AKI was caused by, well, the AKI was caused by blood transfusion, but not by low DO2? Because there are some randomized controlled trials that show that, comparing the liberal and restrictive transfusion, and they found no difference in AKI rate.
Right. So you can't separate them out. So if we went back, and this is where machine learning is going to help us sort out those questions, in my opinions, right? So if you went back to my hierarchy list, right, packed red blood cells, number one. But if you went down the list, you would have seen things like pre-baseline hemoglobin. You would have seen things like the amount of cell saver processed while on bypass, right? So you can't say that the transfusion alone was, although, because that was common in several different scenarios that may have caused that transfusion, right? So some of that transfusion is caused because of preoperative anemia and we have to treat it. Some of that transfusion is because the surgery was a bloody mess, right? and there was a lot of blood loss, and that was evidenced by the CPB auto transfusion value being very high, right? So you can make those associations of, oh, why are we transfusing, right? And did we have a DO2 excursion in those cases, or was it an independent, right, risk factor? And that's what I think machine learning will help us do in the future, is understand these relationships. There were a lot of things we were expecting to be on that list that didn't make the cut.
But I think, George, the other thing to highlight there is there are things on that list that are modifiable, and that's the crunch in all of this, is we can actually make a difference during the case. Tyler?
Yeah, George, I love hearing you talk every time. You're a true inspiration for a lot of us that are trying to take a deep dive into this. My question, and honestly, the last couple of slides, you could probably do just a half-hour talk just on every single one of those parameters and how you're looking at those and, what information you're getting from them. But to keep it brief, the 7 parameters of that perfect perfusion scorecard, one of them was the oxygen delivery greater than 300 with no transfusions. Is there a specific area under the curve, or that greater than 300? Is it, obviously it's not 100% of the case? Are you looking just during cross clamp, the whole case? And if you are looking at a specific area under the curve, what at your institution are you looking at?
So great question. So that analysis was done before we had continuous area under the curve data available to us. But if I back up now and you look at, this is the gauge bar, the dashboard that the perfusionist sees in the operating room, right? So now we have several time elements. You'll see a DO2 area under the curve right next to the DO2, right? And then you'll also see one for the mean arterial pressure. You'll see a map time below. And in that one, we're measuring actual seconds that were below a target, not an actual area curve. So yeah, our 7 metrics of our perfect perfusion dashboard was done before we had this capacity, right? So now we'll modify that. But these area under the curves now are all incorporated into this dynamic GDP number.
Thank you.
Richard?
What a surprise, I'm going to ask a question. One of the things, going back to the blood transfusions, there was a paper released by Oxford University earlier this year, and they were using the organ care system for kidneys. And they were able to show that actually when you give stored banked red blood cells, the storage of it has actually created what effectively is the same affinity as methemoglobin. And so what we are seeing is, well, what they saw is that by transfusing, actually you didn't increase oxygen delivery through that, and it took some time for it to be refreshed, essentially. So re-energized, if you like, is how they put it. I wonder if maybe that is something to potentially think about with that, and whether or not maybe washing the red cells before you transfuse may mitigate that and actually move it down the variable importance list.
Right, totally agree, right? We all know about storage lesions, right, in red blood cells, and the amount of storage lesions or the deformability, right, of the red blood cells change over time. Our average age of blood in our institution when we give it is 22 days old, okay? So it's about halfway expired, right? And it changes depending on the types of surgeries that we have. So if we have a really busy week with, let's say, aortic surgery and a lot of liver transplants going on, the age of the blood gets younger, right? And then if we have a slow week, it gets older, right? But that certainly does impact it, and it can be a reason for AKI in those cases, right? So this tells us that even though we might have a really low transfusion rate, it's not saying we transfuse too much. It's saying that the blood we are giving is the primary cause of our AKI, right? So now what we want to do is look at, well, why do we need to give that transfusion, and what can we do better?
I think that's all the time we've got for this. Thanks. I mean, tonight you'll be there to answer questions over a glass of wine?
Absolutely.
But I do want to say one thing. The really important thing is we need to work out a metric in all of this data collection for collecting washed blood, because the machine learning can only do stuff with the data we've got.
Yeah, and that's very important, and I'm glad you said that, Rob. The results that you get through machine learning are only going to be applicable to your data set, right? So you can't take what I learn necessarily and apply it to your practice, because your experience might be different. And it's only as good as the quality of the data that you feed into it.
Thanks very much, everyone. Join in thanking George.